So diagnostic tests. So how do you know someone has asthma? So their x-ray usually is going to be clear. And can it be not clear? Yes, but they could have like a pneumonia that's triggering their asthma, a viral pneumonia, or COVID-19 could be triggering their asthma. But that's important to see, is there something triggering there? Or usually like an asthmatic is not going to have a clean x-ray, all right? So like if you just like shoot an x-ray on someone who has asthma, it's clean. But the other reason you would do an x-ray is to see what's triggering your asthma. Do you have a pathology that's growing, that's happening? All right, CBC, we can do a CBC and see if they have eosinophils. Eosinophils are for a allergic reaction. So that if you look at the white blood cell counts and you can see the differential and it says, oh, the eosinophils are elevated, that's a sign that they have allergic asthma, which is a variety of asthma. And then also allergies are because of IgEs. So you can actually assess what's your IgE level. If it's high, that could mean that you have risk for asthma. And then ABGs. So ABGs are going to tell us if they have, if their asthma is getting worse. Usually a baseline ABG on someone who comes to the ER with asthma is really important, so we can see, are they compensating or not, right? Because someone with an ABG with asthma is going to have, they don't have a problem retaining CO2. That's not their issue. Their problem is getting oxygen into the bloodstream. So we want to make sure we can see an oxygen on that. We can see a saturation on that. But they should be breathing fast or slow, an asthma patient. Breathing fast, right? And what's the ABG with someone breathing fast? Respiratory alkalosis, not metabolic, but this respiratory alkalosis, right? So that respiratory alkalosis is what you expect. If you see any inkling of respiratory acidosis, that is a big problem. That is a decompensating medical emergency, right? Someone else with the respiratory acidosis, like, oh, I guess they're not breathing good, are they? But if someone with asthma specifically, is a high alert situation. Okay, so even with a normal PCO2, so normal PCO2, we said was 35 to 45. So if we're on the acidotic side of normal, remember we said like 40 is like true north, like 41 is you're good starting to get acidosis, 42, 43, 50, 55, 60, 65. But for asthma, we're not going to wait for it to crack 45. We're going to wait just on the acidotic side normal is a situation, right? When the CO2 starts getting bad, that's a situation. And if it's definitely elevated, that's a real problem. Okay, and now PFTs. PFTs are fun and annoying at the same time. They can be difficult to understand because you have to assess graphs and you have to say, well, does this patient have, does it look like asthma? Is this a good pulmonary function test or not? So usually we send people home with these PFMs, these peak flow meters, and it takes the results of their PFT and it kind of puts it into a device they can take home. Okay, but going back to PFTs, what are PFTs? They're looking at all the different lung volumes that you learn in physiology, right? You have tidal volumes, vital capacities, functional residual capacities, all these different capacities you can measure the lungs. Like how much do they breathe with every breath, right? Which one's that? What volume is that? If you breathe with every breath. That's called a tidal volume. So that's with each tide of your breathing, right? It goes in and out, in and out. That is your tidal volume. And then we have vital capacity. That's the amount of air you can you have to deal with, right? That's the amount of air you can get in and out with testing. So we say breathe in all the way as much as possible, and then exhale as much as possible, right? That is your vital capacity. That's what's going to make you alive or vital, right? That's the capacity to keep you vital. So that's you breathe in, and then exhale all the way to the end, and they can measure that. You put your lips around this little device right here, and it's going to measure how much air you were able to take in and exhale completely, right? That's your vital capacity. And we measure vital capacity with those other neuro processes, other neuromuscular issues, neuro diseases. Which diseases do you monitor vital capacity? Because that vital capacity is that's not a lot of vital capacity, right? So who's at risk of need to put on a ventilator because their vital capacity is poor? Something neuromuscular like myasthenia gravis or Guillain-Barré. It's very imperative that we monitor their vital capacity. We're also going to monitor the ABGs because if they're getting acidotic, right, respiratory acidosis, that's a problem too. That means they're not breathing effectively. That means their tidal volume, which is what gets rid of CO2, is not getting rid of CO2 effectively. Their tidal volume is poor. Okay, so vital capacity and tidal volume. I think vital capacity is probably the one that's going to win out, is the most important one for me looking at these two respiratory diseases. And then asthmatics, they can get all that air out. You just got to give them time. If their airways are bronchoconstricted, they can eventually inhale it all and exhale it all, but it's going to take them a second. It's going to take them more than a second. So what do we say? How much can you get out in a second, right? So we call it a forced vital capacity in 1 second, right? So we say, how much can you get out in 1 second? So breathe in all the way. You ready? You ready? I'm going to time you. And then 1 second later, how much did you get out of your total vital capacity? You get a score, right? If you can get out 5 liters, right, of flow, you say, hey, I can get out 5 liters. I can inhale and I can exhale a whole 5 liters, right? So then, well, that's great. That's 100%, right? You've got 100% of it. Not many people can do that. Normal is greater than 80%. So it means so what's 80% of 5? Where's my math friend at? 4, right? So if you can get out 4 liters in 1 second, perfect. That's normal, right? You inhaled 5 liters, you exhaled 4 liters in 1 second. You exhaled as fast as possible. So here's a normal one right here. So here's 1 second. So my whole vital capacity is 5 liters, and I was able to get 4 liters out. That's 80%, right? So 1/5 is 20, right? 20 or 0.2. So that's how you know with fifths. Either way, we have, if their FEV1 is less than that, that's going to be that means there's a difficulty getting the air out, right? So they have asthma, for instance, or even COPD. There's a difficulty getting the air out in 1 second. An asthmatic patient's going to get it all out, but not in 1 second because their airways are full of fluid, they're full of mucus, they're full of bronchoconstriction, they're full of mucosal hyperplasia. So they're going to have an issue. So their FEV1, their forced expiratory volume, or their forced vital capacity, is going to be less than 80%. So that's the idea with asthmatics. Okay, and we can do a ratio. We can say how much do they get out within of that amount of the 5 liters was your forced vital capacity. That's how much you get out. But in 1 second, you can only get out this much. 4 over 5, right? 4 liters, how much you got in 1 second. 5 is how much you could get out. So 4/5 is 80% score. If they got 3/5, what is 3/5? Every fifth is 20%, right? So 20, 40, 60, 60%. So that's a 60% score. Is that passing? No, right? So that is someone that has a obstructive pattern. They are not able to get out the air completely. So this someone with a obstructive pattern can't get out all that air in time. So like for instance, right here, this patient got like 2.5 liters. They can get out 4 liters. Let's say they got, so that's a problem. With the little caveat with asthmatics is they can respond to bronchodilators. You can give them a bronchodilator and they can actually get out more air. Okay. We talk about COPD patients, we'll find out the reason why they're not going to be able to get out more air. All right, so 80% or less is a asthma patient. Okay, 70% or less is COPD when we talk about COPD. So there's not a lot of overlap between the two. And then we got the peak expiratory volume, and this is what we take home with them. All right, so we say, hey, that's what your score is, and we're going to compare it to your age. I'm going to say someone your age and height and weight should get out this much air, right, in 1 second. So we can measure that. So they can just go ahead and breathe in real quick and do a blowout as fast as possible, and that's going to measure their peak flow meter. And there's more steps to that right here. So you'd repeat it 3 times. So you do the same time every day, right? So not at 8, 12, and 1600. It's going to be at 8 o'clock when you wake up, or 12 o'clock if you're a teenager, right? You're going to wake up and you're going to go ahead and inhale deeply, take a deep breath in, and you should exhale completely as fast as possible, right? And then it's going to be like those little carnival rides, right? It's going to go up and it's going to reach a certain amount, right? And it should reach the green zone, because that's what, when you went to your doctor's office, that's what they assess. That's where you should be for your age and height, right? You should be standing up, right? You got to get out of bed. You can't just wake up in bed. It's like, oh, right? You have to get up and stand up. And then the other piece is don't have gum or food in your mouth, right? Usually that's not a good idea. It's like, oh, my score is so bad. It's like, well, what's all this gum in there, right? So that you don't have different things to make your peak flow meter not work after a while. You take a deep breath as much as possible, as we mentioned, and you're gonna place your lips over the mouthpiece. Don't you got to close your lips, right? You don't want you want all the air you're exhaling to go down that device. okay? And you blow out as fast as possible, right? So fast, hard blast. It's not a slow blow like with like an incentive spirometer, which is actually incentive or inspiration. This is expiration, okay? You're going to empty out your lungs completely as fast as possible. All right, so reasons to perform this. Why do you do this? We can measure when they do those little markings on there, right? You got little markings right here. This is 80 to 100% of where they should be, right? That's where they should be 80 to 100% function, right? When they start dipping in function because they're bronchoconstricting over time, now you can be at 50 to 80%. That's not good. You're at half your function or better. If you're less than 50% of your function, that is a situation. You have to seek out care, okay? So you have to have a peak flow meter, and you have to be measuring that, and that can tell you how bad your asthma is. And they can say, oh shoot, I'm in the yellow zone, and let me take my bronchodilator and see if I get better, right? If they're using bronchodilator like 2 times, 3 times, 4 times to get better, and they're still like in the yellow zone, that's a problem. It's kind of like a nitroglycerin situation, right? I'm taking it and not getting better. I need to go seek out help. Okay, so it's an important reason to decide when to call 911 or not. Okay, so what's the treatment for asthma? How do you fix asthma? So this is where it's based on what kind of type of asthma they have. If they have allergic asthma, they might get some of the fancier medications down here, these immune modulators, where we're going to stop the specific IgE, that specific IL-5, that specific IL-4. But really the kind of meat and potatoes is these guys right here. Our beta-2 agonists, right? And we want agonists because agonists are going to normally do what the SNS does, which is bronchodilate, right? That's why we say beta blockers have caution because those could bronchoconstrict. But bronchodilators, those are going to be our usual go-to with a asthma patient. You have what are called short-acting and long-acting beta agonists. So these guys, the short-acting ones are going to work now. So obviously those are the ones they want to have in their pocket. They want to have on them at all times. That way they can inhale. If they get into a situation, they can take that right away, and hopefully it opens up their airways, right? So these are ones you want to use PRN for an asthma exacerbation, okay? So you want those there at all times. You want that available at all times, okay? What else? So the goal with these medications is to avoid symptoms and avoid being hospitalized, avoid exacerbations of asthma. So obviously non-pharmacologically, you want to make sure avoid modified risk factors, make sure they're cleaning their house, make sure they're washing their sheets every week, make sure they're fluffy. They got to decide if they like fluffy or not. They got to make sure that they are avoiding all of these complications that may happen. And then also teaching deficits. Are they measuring their peak flow meter routinely? Are they going to the doctor to assess if they need more medications or not? Because there's different steps of how bad someone's asthma is. When you get to step 5, you have really, really bad asthma. We're going to be adding a lot more agents to try to fix their asthma and prevent exacerbations. Okay, so we have controller meds, reliever meds, and we have some other agents we can throw in there, like our biologics and anti-leukotrienes, right, that are part of the inflammatory cascade that we can hopefully get rid of, right? We hopefully or inhibit. So controller meds, these are what control your asthma over time. Usually these are an inhaled corticosteroid. So corticosteroid is, and we'll talk about how it works, it's going to stop the whole cascade of events. It's going to stop all the release of prostaglandins, the release of histamine, the release of interleukins, leukotrienes, all the things, right? So steroids are a great start. You can see that inhaled corticosteroids are always around for all 5 stages of asthma. And then, we also always have a SABA, a short-acting beta agonist. That's always around as well. That's there for any kind of event that might occur. If they get triggered, they have an incoming stress, they have any kind of problem, we have that available for our use. Okay. What else? And we have other drugs such as a SAMA or LAMA, so a short-acting muscarinic antagonist. So a muscarinic receptor is just acetylcholine receptor, right? Remember, acetylcholine's on the muscles. Acetylcholine's also on the muscles of the bronchioles. So we have a short-acting one and a long-acting one. Okay, as we'll talk about those in detail, or just how they work. But this is your overview of how our different agents are working, right? And then we'll talk about how you give it correctly. Make sure you're taking your inhaler correctly. You're actually taking the full dose in. Budesonide is a steroid. Okay, it's inhaled corticosteroid. All right, so Saba-Laba and Sama-Lama. So these are our bronchodilators. These are our go-to agents that we're going to be on. So Sabas are always available at all times. They need to be available there. Labas are always combined with something. They're never by themselves. So never give them alone. They usually are going to be combined with another agent, because otherwise the beta agonist can cause a it causes a widespread side effects, but also it's going to have it can have a rebound bronchoconstriction, which is not great. Okay, especially if they take it off right away, like they're on a LABA. Like remember we mentioned beta blockers. You never like spontaneously take them off, right? You can have rebound hypertension with beta blockers. It's kind of the same thing with LABAs. You can have a rebound bronchoconstriction if they forget to take their med, or they're living paycheck to paycheck and they can only afford certain things. They run out of it and they can't just go to the store and get a refill. They have to wait till payday Tuesday or whatever. It's going to take a second. Okay, so LABAs can never be alone. LAMAs can, SAMAs can, SABAs can. That's fine. But LABAs with specifically asthmatics, you're not going to have them by themselves. Okay, so what are beta agonists doing? They're potentially this mechanism for bronchodilation. That's what they're designed to do. Acetylcholine, we know, is stimulating what? Bronchoconstriction. So do we want acetylcholine? No, we want anticholinergics. Okay, we want to block acetylcholine. We want to potentiate norepi, epi, and the SNS. Right, that's what we want. If we potentiate the SNS, what symptoms are we going to get as a side effect? SNS symptoms. We're going to get bronchodilation, but we're going to get increased heart rate, hypertension. They might get tremors, they might get palpitations. So that's the idea with bronchodilators that are beta agonists. As far as anticholinergics, well, it's the same thing, just extra steps. We're stopping acetylcholine's function. You're also stopping acetylcholine's function on the heart. So therefore, the heart rate's going to go which direction? Up, right? Acetylcholine via the vagus nerve on the heart causes heart rate to go down, right? So if we stop that, we're going to have a rise in heart rate, right? It's the same side effects. Okay. Also, the benefit of acetylcholine not only on the bronchial tone. Remember those mucus? Here's our parasympathetic nerve, our vagus nerve right here. Our vagus nerve stimulates the mucus right there, all that mucus production, but also it causes our airways to do what? Bronchoconstrict or dilate? Bronchoconstrict. So we want to stop that. Okay. Side effects, it's SNS activity because we're taking away the brake. Now all we have is accelerator. All right. And it's usually used for late asthma. You don't usually see it in early asthmatics. All right. So as far as like the names, again, with beta agonists, they all end in OL. LOL is for beta blockers. OL is for beta agonists. Well, isn't technically a beta blocker end in OL also? So that's a shower thought. But anyways, it ends in OL. Just OL. It doesn't have like an LOL, right? So it's just there's like something besides LOL. It just ends in. That's going to be a beta agonist. Okay. And the difference between SABA and LABA, it's kind of up for grabs. There's like no real clues, but albuterol or levalbuterol is an example of a short acting. Okay. And then as far as our bronchodilators that are SAMAs and LAMAs, those guys end in tropium, which is nice. Okay. Like which one's the long acting? It's kind of hard. I mean, you got tiotropium is a LAMA. So like oncle is on side of on a LAMA right there. That's the best I got. All right. So that's the idea behind these bronchodilators.
Can I speak Spanish? Let me try. Saba, Saba, Sama, Sama. Sounds like Spanish to me.
So SAMAs sounds a little Spanishy, but it's also one of our go-to agents. All right, so corticosteroids. So these guys, we have IV forms and PO forms, but this one is our go-to is usually our inhaled form. This is a preventer. It's preventing the airways from contracting. Okay, so it's going to go in there and it's going to stop all the inflammatory mediators we talked about, all those inflammatory chemicals, chemotaxins, interleukins, leukotrienes, mast cell destabilization, prostaglandin formation, all those things get stopped with steroids. That's nice. So you can see steroids are working right up here. And they're stopping the formation of the bronchi from getting bronchoconstricted. That's kind of the overview. Sorry, over here, steroids are stopping all this breakdown. Arachidonic acid, we've heard about that with aspirin, right? So we're stopping the formation of all these leukotrienes, all these prostaglandins, all these things that were causing the inflammation before, we are stopping with steroids, which is nice. That's why there always are kind of our baseline. Okay, we have inhaled corticosteroids, or ICS, inhaled corticosteroids, and we have OCS, or oral corticosteroids. So steroids are great that they stop inflammation. They're anti-inflammatory, but they can put you at risk for a overgrowth of infection, right? Overgrowth of fungus as well. So with inhaled corticosteroids, we have this overgrowth of Candida, a yeast, right? So that yeast can grow on the tongue and that can cause thrush and cause voice changes, right? So the tip and trick is to make sure you wash your mouth out after you cuss, or also after you take ICS. That needs to be fixed, right? That's going to help wash out the steroid, because we don't want the steroid on the tongue or the esophagus. We want the steroid where? Deposited in the lungs, right? That's our goal with these guys. And then we have oral corticosteroids. The inhaled corticosteroids are not in a high enough dose to make it through the lungs into the bloodstream. They're not at a high enough dose. But oral corticosteroids, of course, are getting absorbed through the GI tract and they go through the liver and through the bloodstream. So we get side effects of steroids with oral corticosteroids. And this is usually more advanced asthma when they actually need this, because they're going to otherwise be at the hospital with an asthma attack. So now we get all the side effects of steroids, right? Corticosteroids. We're at risk for infections, right? Because we have what do steroids do besides stopping the whole breakdown process? They stop the infiltration of macrophages and such getting into the bronchioles in the first place, getting into the lungs in the first place. So they are stopping that, because once they get in there, they're going to start causing havoc, right? So that's the benefit of these oral corticosteroids, it's stopping the white blood cells from migrating into the target area. But all of our symptoms of steroids are all based on what steroids do, which we talked about in diabetes, right? They break down what? They break down sugar, glycogen stores to make more glucose. Well, we can get glucotoxic, which causes diabetes. So long-term steroid use can lead to diabetes development. And then we start breaking down lipids, lipolysis. You break down lipids, that's going to make all the lipids, in your extremities get broken down. And then they say, hey, where's a good place to put the lipids now? So they say, well, let's put it on your face. It's called moon faces. Their face looks very, very swollen. They say, I'm going to put it in another area that's not so, unsightly. I'm going to put it on the back of your neck and call it a buffalo hump. So it's like, well, okay, thanks. And we call it a buffalo hump or a dorsocervical fat pad. So that's another area that the fat will take away from the legs. They got really thin legs, and they put it on the face and the back. And they put it on the belly, because that's a good place to put it too. Right? And the other thing is they break down proteins. So we break down sugars, we break down fats, and then we break down proteins. And we break down proteins, that's, what's the most common protein in the whole body? It's found everywhere. You can buy it at Walmart.
Just look at it. I mean, I
Yeah,
had 13 out of 38 fail.
Yeah.
Even after I allowed for 6 months.
Oh, look, yeah. So what's the most common protein you can buy anywhere? Or I guess you can buy, it's pretty common. It's in every lotion ever. No, I'm not going to put that on my skin. I'm not putting whey protein on my skin. And whey protein is not found in a human body. Whey protein is found in the cow body. Right? Dairy cows make whey. Collagen. Collagen is the most common thing. Most common protein in the whole body. It's found in the skin, right? Keeps our skin nice and elastic. It's like, you know what, I'm going to put collagen on my skin. For some reason, in some way, it's going to go through my skin and fix the collagen underneath my skin. That doesn't work. So collagen is in our skin, and our steroids are going to break it down. So now I got thin skin, paper thin skin, right? I got collagen. Where else is collagen found? Vessels, good. Vessel walls, right? Or the collagen in the vessel walls. So now I have easy bruising. So that means when I get hit, my collagen is broken down and my vessel is going to rupture and I'm going to get easy bruising, right? So easy ecchymoses. And so that's the vessels, we get easy bruising, we got paper thin skin, and then we have collagen where else? Get bones. Our bones are made of like 97% collagen. So you have bone fractures are a risk as well. And then also we get striae. So besides having that dorsal cervical fat pad and the moon facies and central adiposity, we also get striae because that's the skin, that's being stretched and it can't repair itself that nicely. So we have all that collagen breakdown in the skin as well. Okay, so those are all the side effects for steroids. This is not going to change. This is steroid side effects we've documented since for the last 150, 200 years. Okay, and those are the reason for the side effects. You just gotta break it down. I get this, this, and this, and there's some other random stuff like it causes mood disorders, personality changes, like the wrestlers are on steroids. They're gonna, that's kind of a different steroid, but it's kind of related. But they start killing their family. It's like, well shoot, that's mood changes. That escalated quickly, but that is a possibility. Okay, so leukotriene modifiers. There's the other fancier ones. They're more expensive, and they are going to stop, like we mentioned, all the different interleukins, all those chemicals that are causing the widespread vasodilation and leakiness, but also the widespread mucus production, the widespread mucosal edema, widespread bronchoconstriction. So we give these agents to stop that. So we have leukotriene modifiers. These guys are going to prevent those leukotrienes from doing their thing. And their thing is to bronchoconstrict, edema, mucus, make more eosinophils, and well, shoot, that's going to then now start the cycle all again because eosinophils do all this stuff. They bring all the milkshake to the yard. That's not how the song goes. Anyways, it's going to start all that they're going to create all this activity from happening, just like our friends who are visiting right now. So if you give a leukotriene modifier, they go, shh, stop it. All right, that'd be a leukotriene modifier. Okay, side effects are rare. It's usually like a bleeding kind of situation. And you can see right here is where our steroids at. Our steroids are up here, right? They're stopping right there. Our leukotriene modifiers are also stopping that breakdown from occurring. Okay, and then we got immune modifiers. These are monoclonal antibodies, and they're only designed for these one things. And again, they have random people's names who discovered them, their initials. They put them together and say, hey, Oscar. What's another M name? Melissa, right? So Oscar and Melissa and Andy and Liz, omalizumab, right? So we discovered this medication that binds specifically to IgE and shuts it down, okay? And this medication binds specifically to IL-5, shuts it down, right? Binds specifically to IL-4 and shuts it down. These are usually given sub-Q, okay? So these are sub-Q shots. We're stopping all of these processes that are, it all goes cascade out of control, and we can find these certain linchpins. If we shut them down, it'll stop the whole process. All right, so inhalers. So how do you use an inhaler correctly? So an inhaler needs to be inhaled. So that's step one. Make sure you're inhaling when you use an inhaler. All right, so a peak flow meter is inhalation or exhalation? Exhalation, right? So our peak flow meter down here is exhalation, right? You're exhaling as quick as possible. You're standing up, you're not using gum, food, etc. Don't use gum or food with your inhaler either. So you want to make sure that you are inhaling with this one. And you blow super fast with a peak flow meter. Blow as fast as possible. What about a MDI or a metered dose inhaler or a inhaler? You're going to inhale how fast? Not fast. You're going to do it slow. You do it as slow as possible. Okay? So inhalers, there's different varieties of inhalers. MDIs, metered dose inhalers, are the most common. Okay, and these guys, so we got different varieties out here. Ones that like crush a pill. This guy right here crushes a pill, and then you can inhale it. But these guys are going to be inhaled, and they're going to get deposited hopefully in the lungs. Okay, so what's the process? How do you teach this? Because it's important teaching. Make sure they're doing the correct process. Make ordered steps. These are great questions to ask, right? So A, remove the cap, just like the Pop-Tart instructions, remove from bag before I put in toaster. Same thing with the meat. It's like, it's not working. I'm not feeling any kind of relief. So, well, how are you doing it? I'm doing this. Well, shoot, you got to relieve. You take the cap off first. All right, so take the cap off. You're going to breathe out completely, and then you're going to breathe in once we're ready, right? So you press the button at the start of inhalation, and you're going to inhale as much as possible. So, and you inhale as much as possible. That's with your lips around the container, right? You don't want it to be going out to the side like Dumb and Dumber, right? It's going out to the side, banaka, right? So that's not gonna work as great. So we want to make sure we have our lips around it. We are inhaling as much as possible, and then you hold your breath for at least 1 minute, right? So I'm sorry, at least 10 seconds. 1 minute is between doses. So you hold for greater than 10 seconds. If you can do a minute, more power to you, right? If you do 10 minutes, right, and then now you can be invited to Avatar 3. So that's a whole thing to to make sure you are inhaling as much as possible, is depositing as much as possible, and it's there, right? That's our whole goal. And if we have to do like 2 doses, like the dose is 2 puffs, then we got to wait 1 minute between puffs. Okay. And then what else? If you're using an inhaled corticosteroid, what do? First you curse and you cuss, and then you wash your mouth out, right, with your inhaled corticosteroids. And then what's finally? So finally, you're gonna replace the cap, right, when you're done, so that it's clean for the next time. And what happens if you don't wash your mouth out? What will develop? It'll develop thrush. And how do you fix thrush? Antifungals. It's a fungal process. So nystatin is the medication to fix it. All right, so we have all kinds of different MDIs out there, and then sometimes those 5 steps are very, very complicated, so we tell them, let's just use this device right here called a spacer. So a spacer is going to hold the medication for them, so they don't have to worry about all the different steps or removing the cap, or they still have to remove the cap. They don't have to worry, like, oh, do I exhale or inhale? What do I do? All you do is into the spacer, and then when they're ready, they put their mouth around it and inhale. Okay, so it cuts down on the steps, but then you have to carry like this on it's like a huge device that you have to carry around on airplane luggage. It doesn't really pack away that easily, and obviously kids, they're not going to be able to coordinate all the different steps, right? So that's the idea. Spacers is remove the cap, shake it. I didn't mention shake before. You want to shake the solution so that it's actually going to propel. Okay. So that's the idea with spacers and MDIs versus PFMs, right? PFMs, you do exhale or inhale? Exhale. Which one do you do fast? PFMs or MDIs? PFMs fast. F for fast. It's a good one. All right, and then you got if you have to do repeat doses, right? How many times you have to repeat things? Let's say there's a repeat dose for the MDI. You have to wait how long? You have to wait a minute between doses, right? And then for PFMs, you have to do 3 trials and average them. Okay, so asthma teaching. So the teaching is, again, avoid all these triggers that may occur, right? You got to wash your blankets every week. I'm guilty of not washing my blankets every week. So you got to wash all the bedding, all the stuff, and you got to throw it in the wash. You got to decide what you're going to do with the family pet. You have to make sure that you're going to avoid dander. You get HEPA filters, you get those air purifiers. All these things can be used to help avoid triggers, right? Don't smoke if they are smoking. Make sure they're getting their shots. Why do they need to get their vaccinations? Because a significant trigger is the flu, or COVID, or pneumonia. Those are significant triggers for a asthma attack that we want to avoid. Okay, avoid dander and dust. Use a HEPA filter. Wash sheets. Avoid carpets. So now they need to upgrade to hardwood floors. Now's the time. Okay, so when to call. So there's different tips here. So basically, you're having the rule of 2s, right? You're using your inhaler a lot. You're using your coughing. You're waking up 2 times during the night. That's a situation where you maybe have to consider, maybe I need to get some more care, maybe I need to see my doctor. Definitely if I'm using my PFM and I'm in the red zone, right here, that's less than 50% of what I should be doing. I'm in the red zone and I take a bronchodilator and it's not recovering, that's a time to seek out emergent care. Okay, so what is that complication? It's asthma exacerbation, right? So they have to come to the hospital, and that's when their PFM is less than 50%. They're in the red zone there, and they need to have a intervention. They might need to get some more treatment. They need to get like a albuterol inhaler over an hour or so. Also, we hit them up with IV magnesium. Magnesium relaxes everything. Like when you talk about OB, it's going to relax everything, and when you talk about the lungs, it's going to relax the lungs as well. Okay, so what else? The frequent use of SABAs, that's going to be with no relief. That's going to be a problem that they're probably an asthma exacerbation. And then if they're taking PO steroids at home, the PO OCS, right? They might need to get an IV form. They get IV form of glucocorticoids. Okay, so IV glucocorticoids, we give them oxygen, we give them all these things to help turn them around. And how do you know they're getting worse? What are they doing for you? They have signs of hypoxia. They got signs of accessory muscle use. They're talking in shorter sentences, right? What if the wheezing goes away and now there's no air movement on the left side and right side? Is that good? That means the airways are completely shut, right? They're all the way shut in asthma exacerbation. All right, so steroids, IV form, we got bronchodilators, magnesium, these are the medications we give for someone who's getting in trouble with an asthma exacerbation. And then the last thing is, the ABG. So when we say about the ABG, what's a bad ABG? A bad one is one with a high CO2.